Virtual Unit Peer Leader Annual Training developed in consultation with earlymobility.com. This module is one of several modules designed to help you with your annual training, or really anytime you want to do training to help with your unit peer leaders or your safe patient handling and mobility program. The module bundle includes what it means to be a unit peer leader, roles and responsibilities of being a unit peer leader, mobility screening, how to perform and use the VA Mobility Screening and Solutions Tool, or the MSST, building mobility into daily care, how safe, early and continuous mobility, or SECM, can actually save you time throughout the day, equipment review, lifts and slings, key considerations for purchasing equipment fair and sustainability of your program, crucial conversations, understanding and overcoming conflict and resistance to improve compliance in your program, and how to be the most effective educator you can be, getting the most out of training and education. This module is on the mobility screening, how to perform and use the VA Mobility Screening and Solutions Tool, the VA MSST. A disclaimer, earlymobility.com does not endorse any one product or product vendor and does not sell any SPHM technology. The videos used for these modules are purely representative of the types of SPHM assistive technologies available, and there are many versions of all the technologies that you see in the videos. Check with your SPHM program manager to determine the model you have in your facility. The Mobility Screening Solutions Tool is a valid and reliable tool for screening mobility levels across all caregivers, both licensed and unlicensed. The citation is provided for you in this slide. Before you begin the screen, you determine if your patient is currently walking independently without assistance or support and is walking with good safety awareness. If they come walking into a clinic like you or I without any problems, you already know that they are mobility level 4, independent ambulator. However, if they are not walking independently and safely, you start your mobility screen and work through the steps, and you will see that there are basically 5 levels of mobility. Level 0 means the patient is unavailable for testing. And then you go through level 1, 2, 3P, which is powered, and a 3N, which is non-powered. And then a 4A, which is adaptive, and a 4, which is non-adaptive, independent ambulators. So let's look and see how we do the VA Mobility Screening and Solution Tool and how we determine the patient's levels. Welcome to the Mobility Screening and Solutions Tool. Our goal across the Veterans Healthcare Administration is to safely move and mobilize all of our veterans to their highest potential and to keep our caregivers safe in the process. In order to do this, we need a common language and a standardized way to determine how much our patients can safely move by themselves and what activities they require physical assistance with. All care team members, including patients and their families, must understand the terminology and how the MSST can keep everybody safe. There are 3 types of movement to consider. First, passive transfer, where the patient needs to be moved without actively participating in the movement. For example, if they're sedated and they must be moved to a special diagnostics table, or if they've had multiple trauma and need to be moved onto an operating table. Secondly, during daily mobility, when the patient is participating in daily activities during hospitalization, such as getting up for meals, going to the bathroom, performing daily hygiene, etc. In this case, the goal is to stay active and to avoid hospital deconditioning as the patient recovers from their acute illness or injury. And third, during rehabilitation, when the patients are actively trying to increase their independent mobility through a structured exercise and activity program. The Mobility Screenings and Solutions Tool has 2 main purposes. 1, to establish how the patient can move right now. This is their baseline status. And 2, to inform decisions about how to safely accomplish the desired activity. First, Determine that the patient is available and does not have strict bed rest orders or bilateral non-weight bearing orders. Begin the mobility screen to see what the patient can do. Ask the patient to try and sit up. The patient can use the bed or the bed rail if they need to, but what you are looking for is that they can sit safely unsupported and they can shake your hand across the middle of their body once they get there. If the starting point is a chair, ask them to sit forwards and stay in that position without resting on the backrest or using their hands for support. If they cannot, then you know they need help even to sit. This patient is level 1 and requires total assistance. If the patient successfully passes step 1, you know they can sit up independently and you advance to the next step. The next question is, can they stand up safely by themselves or do they need help? Before we even ask them to stand, we need to know if they have good strength and movement in their hips, knees, and ankles. Trying to stand up when both legs are weak and do not have the movement needed puts the patient at risk for a fall and also puts the caregiver at risk for an injury. Ask the patient if they can stretch out their leg and point their toes. They must be able to almost fully straighten at least one leg to pass this step. If they succeed, you know they have enough strength and movement to go on to the next step. If they are unable, they will remain at MSST level 2 and require moderate assistance. The action of raising the butt cheeks off the surface from sitting to a standing position also requires the gluteus maximus or the buttock muscles. Ask the patient to try and stand, clearing their buttocks from the bed or the chair and holding for 5 seconds. They should be able to stand safely without swaying or faltering for the full 5 seconds. If they are unable, they will remain level 3P, which means they need a powered device to help them stand up. If they succeed, even if they have to steady themselves on the bed rail or a cane or a walker, you know they are safe to stand and can progress to the next level. You now know that they can sit up and stand up independently. Next, you need to determine if they can walk safely by themselves or if they need help. Ask the patient to march in place and then step forward and back with one foot and then the other. They should be steady and have no loss of balance. If the patient is unable, they remain level 3N, which means they will need assistance to walk. If they succeed, they advance to the next level. If the patient has passed all the mobility screening steps, they have demonstrated the ability to sit up, stand up, and walk independently. They have reached level 4. If they need an assistive device, they are MSST level 4A, which means independent adaptive. If they do not need a device, then they are simply level 4. So let's just review the levels one more time. Level 1, total assistance. The patient can move in bed, but cannot safely and independently sit up and shake your hand, crossing their body without help. Again, level 2, moderate assistance. The patient has enough strength and balance in their body to sit up and shake your hand, but they cannot completely straighten their knee and point their toes on at least one leg. It is not safe for them to attempt standing without help. Level 3, minimal assistance. The patient has enough strength and movement to attempt standing up. 3P, these patients need powered devices to help them stand, as they are unable to stand for 5 seconds without swaying or faltering. 3N patients can stand without swaying or faltering, with or without support from a device such as a cane or a walker or a stand aid, but cannot step forward and back steadily and with good balance. They cannot walk without help. Level 4 is independent. The patient can stand up safely and independently. They can step forward and back steadily without losing balance. If an assistive device such as a walker or a cane is needed, they are level 4A. If no device is needed, they are simply level 4. This slide shows you the different levels and the anchors that we use to describe these levels. So you saw it in the video, but level 1 needs help to sit or requires total assistance. And you'll see this in the documentation. A level 2 patient can sit independently. They are an independent sitter, but they need help to stand and walk. They do not have enough strength in their legs to try standing without an assistive device. A level 3P or powered needs help to stand also, but they have enough strength in their legs to try standing before you see if they need a device or not. A level 3N patient is able to stand safely, but they cannot step and march. A level 4A can walk independently with an assistive device, and a level 4 patient can walk independently without a device. So this is just another way of laying out and describing the different levels for you as you are making those mobility decisions and safety decisions for you and your patient. So the first thing you do is you decide if the movement is a passive transfer or if it's regular daily mobility, and you saw this in the video. Let's check your knowledge. You're in the radiology department and a patient comes in from the emergency room on a stretcher. They need an MRI of their brain with tentative diagnosis of cerebral bleed. Moving this patient onto the MRI table and back is an example of what? Passive transfer or regular daily mobility? If you answered A, you are correct. This is a passive transfer because we don't want the patient to move. We don't know if they have a bleed. Let's check another scenario. You're in the dental clinic and a patient comes in a wheelchair for their oral cleaning appointment. They need assistance to get from the wheelchair into the dental cleaning chair. This movement is an example of what? A, passive transfer, or B, regular daily mobility. This one is regular daily mobility. Getting in and out of a chair, on and off a different surface is considered part of regular daily mobility. What about this activity? You're on the medical surgical unit. Your patient rings the bell to request assistance getting up to go to the bathroom. This movement is an example of A, passive transfer, or B, regular daily mobility. The correct answer is B, regular daily mobility. What about this one? You are on the medical surgical unit again. Your patient rings the bell to request assistance repositioning in bed. This movement is an example of A, passive transfer, or regular daily mobility. A lot of people will mention that this answer is passive transfer because we tend to do it passively for the patient, but it is actually part of regular daily mobility. You and I, when we move ourselves in bed and change position, that's regular daily mobility. And the message with this particular scenario is don't automatically assume a veteran cannot move themselves in bed. Give them an opportunity to try. Passive transfers in bed level or strict bed rest. If your patient is on strict bed rest and should not yet be actively participating in the mobility, use the devices you would use for passive transfers. So you have air assistive technology, you've got friction reducing devices, ceiling lifts with repositioning slings, floor-based lifts with repositioning slings, a ceiling lift with a seated sling, or the bed features. These are different examples of technologies that can passively move a patient without them participating in the movement. Which of the following patients should be passively moved with full body support? A, a patient with suspected fractures. B, a patient in a coma in the intensive care unit. C, a patient transferred onto the operating room table. Or D, All answers are correct. The correct answer is D. All of these are correct answers, and the patient should be passively moved. So when we go to move our patients throughout the day, the first thing we want to do is check with the care team or the RN to see what the mobility goal is for your patient for that shift. The mobility screen tells you how much of that goal they can do safely and independently by themselves, and which parts of the movement they need help with. Examples of mobility goals include exercises in bed and bed mobility, sitting up over the side of the bed, a goal of transferring or standing up using your own feet, or walking or ambulation. The first thing we do is we determine what the patient's baseline is. What could this person do before they came into our facility? When the patient is admitted, either the nurse, the case manager, or the provider will determine if they are at their baseline, if they're at their normal mobility level. If therapy is ordered, they will then confirm or determine the baseline mobility level. Mobility screening helps you decide the appropriate devices and the appropriate care decisions to keep everybody safe. When we think about daily care of our patients, consider how they did things before. Can they move like they did before? If so, it is very important to help them stay at their baseline. If they're not at their baseline and not improving with medical intervention, then that would be an appropriate consideration for a therapy consultation. Mobility should be incorporated into all daily care, just as it would be for you and I moving about during our day-to-day activities. We need to understand that leaving a patient in bed creates more harm and creates more that the patient has to recover from when they leave our facilities. We will learn more about this in the module on building mobility into daily activities. We need to understand how quickly a patient can deteriorate when they don't get out of bed. We'll learn more about this in the building mobility in module, where we look at the harms of immobility in a little bit more detail. But for this module, we just want to look and see how quickly some of the harms of immobility occur. Contractures, muscle atrophy, pressure areas, plasma volume decreases. These things begin within the first 24 hours of immobility. So leaving our patients in bed really isn't an option. We have to figure out how to keep them functionally independent and what equipment we need to use to help them do that. Now we're going to take a look at your documentation of mobility. This is a screenshot of the VA AES mobility documentation note and is found in the nursing admission assessment and the daily shift assessment. And there's also mobility language on the frequent documentation note of the VA AES. Many facilities are also looking at how to build mobility screen language into the Pisces notes, the ICA notes, the Caribou notes, and all documentation areas throughout all care settings. So for this note, you'll see that in that shift assessment or the admission assessment, there's a spot for mobility. You're going to select this box. Level 1, total assistance, needs help to sit. This patient is unable to sit up independently. They require total assistance. This means they need help with sitting, standing, and walking. It does not mean they cannot sit up, stand up, or walk. It means they need a mechanical lift to help them. We are purely replacing the manual assistance with a lift assist. You will see that a total assistance patient can still use an ambulation harness. Imagine a patient who had a total knee replacement yesterday and needs to walk, but is just a little unsteady because maybe they've had a really bad night and they need steadying to sit up. So you're going to check the box total assistance if your patient is unable to sit up without help. Examples, Your patient is waking up from sedation in the ICU and is on a ventilator. They're extremely weak and cannot even begin to sit up by themselves. They may be able to sit with assistance of a seated sling, but this is a maximal assistance activity. This is MSST level 1. Total assistance, needs help to sit. Let's think of another patient. Your patient has pneumonia and was walking yesterday, but they feel lousy because they were allergic to the antibiotic given. They're dizzy at the edge of the bed and you do not feel it is safe to let them sit by themselves. They should be walking today, but they need a device in case of dizziness or falling. This patient is also level 1 and requires total assistance. Again, it doesn't mean they can't or shouldn't walk. It means that they require a mechanical or a powered device to help them to keep them safe and to keep you safe. The third example, your patient has been placed on strict bed rest orders until a DVT has been ruled out. This patient requires total assistance because they are on strict bed rest orders and should not get out of bed. These are all examples of total assist, needs help to sit, level 1 patients. Level 2, moderate assistance, independent sitter. Like we said in the video, if the patient is able to sit independently, the next question is, do they have the strength to try and stand up? The stretch on point is a very, very important step, which is why it has its own category in the screen. Traditionally, once a patient has sat, a nurse would try to have the patient stand without checking leg strength. This is where many staph injuries occur and many patients fall because their legs buckle when they go to stand. If they are unable to stretch at least one leg and point their toes, they remain moderate assistance level 2. This means you don't even try to let them stand up without a device. You still can have them stand and walk, but you know you need a powered device to even stand up. If they're able to stretch and point, then you go on to see if they can stand on their own. But if they can't, you've got your level and you move on and you know you need power. A level 3P, powered. This patient also needs help to stand and is moderate assistance. And you'll see this in the note, moderate assistance. In the notes themselves, you will check moderate assistance for both a level 2 and a level 3P. The difference is whether you try to go on and finish the test or whether you stop at a level 2 and grab your lift. So a level 3P can sit, they can stretch, they can point, but they cannot stand fully or partially without faltering for 5 seconds. Many have asked, why not just combine levels 2 and levels 3P? The reason is that this would result in the stretch and point being missed and skipped over. And this is one of the big changes with the mobility screen, is we check the leg strength before we stand up. Level 3N, this is a person who can sit up, they've got good leg strength, they can stand, but when you go to march and step, they lose their balance. Remember, if they cannot stand safely without loss of balance for 5 seconds, they're going to remain a 3P. Level 3N patients can stand, but they need help to walk. Remember, the goal is what they should be able to do: sitting, standing, transferring, walking. The screen is what equipment you need to help them do that safely. In your documentation, a 3N will be documented as minimal assistance. This person can sit up, stand up, but they need help to walk. A level 4A patient can do with sitting, stretch and point, standing, stepping with an assistive device, and they are safe and independent with their device. For regular daily mobility, they can use their device independently. We must also assess fall risk for any of our ambulators that we are going to allow to walk without supervision or assistance. High fall risk does not change the VA MSST level, but will guide a fall arrest device in case that patient falls for either a medical reason, such as an arrhythmia or pain, or they get tired, Or sometimes we have patients who have psychological or behavioral falls. They may still be a 4A or a 4 on your MSST, but if you're worried about them falling, you may choose to use a device for that reason. There may also be some instances in structured rehabilitation, such as working on balance or high-level gait activities, where therapists may use an ambulation harness or equipment to push activities to a higher level for our patients. In your documentation, you're going to check independent, but then with the equipment, you will check whether or not they're going to use an assistive device. In the prior screens, each level will drop down equipment options for you to choose. It's very important that if your patient requires total or moderate or minimal assistance, that you check the boxes for the appropriate safety equipment. Level 4A, consider if this person would be safe getting up on their own with their device if you are not there. Do they normally use a device to get around? Has therapy documented that they are safe with their device? Can they take steps safely and independently without a device? Do they have new fall risk factors? These are things you want to consider in your 4A patients. Level 4 is you're independent, they're up and about, you don't need to worry about them falling or losing their balance. If you do worry about them falling, you may still use a device, not because they cannot march and step, but because, like your 4A patients, they have other fall risk factors, or again, in rehabilitation, where the therapist may be pushing balance and gait activities. In your frequent documentation note, you will see the activity and mobilization order, and you will see the mobility status again. The last mobility goal from the prior note will pull forward into your frequent documentation note. And you also have a spot to check how well they tolerated their mobility. In your frequent documentation note, you also have your Johns Hopkins highest level of mobility. This is another way of documenting your goals. So we talked about bed activity. This can be a Johns Hopkins 1 or 2, lying in bed or turning yourself in bed. Level 3 is sitting. If you want to transfer or stand, that's going to be a 5, a 4 or a 5 in the Johns Hopkins. And then your walking goals are a 6, 7, and 8. And those are differentiated by the distance your patient is walking in your JHHLM, which is your Johns Hopkins goal. So the goal, remember, is based on what this person should be able to do and what they could do before they came into hospital or your facility. The mobility level, that's going to determine whether or not you use equipment and what kind of equipment you need to help them with their goal. So this is what we call a bridging document, and you'll see this used throughout our patient care scenarios to determine what the goal is. You're going to go across the top of your bridging document. Is our goal bed level, sitting, standing, and transferring, or is it walking today? Remember, our goal is based on what the patient can normally do and what they're here for medically. And then your mobility screen is going to determine what equipment you're going to use. You also are going to use your fall risk tool. So let's practice with some different mobility levels. Scenario 1, your patient can sit up by themselves with the help of the bed rail. Once sitting, they can balance and reach across their body to shake your hand without losing balance. They cannot stretch either leg or bend their ankles. What is their mobility level? Total assistance, needs help to sit, level 1. Level 2, moderate assistance, independent sitter, but lacks enough strength in one leg to try and stand without a device. Level 3P, moderate assistance, has leg strength, but still needs help from power to stand safely. Level 3N, minimal assistance, can stand without loss of balance, but needs help to walk. 4A, independent adaptive, or level 4, independent walker. Hopefully you answered level 2. They lack the strength in either leg to try and stand safely. So this person should be able to stand and walk with an assistive device if that's their mobility goal. But we're not going to try and stand without a device because we know that they have weakness in their legs. What about this scenario? Your patient can sit up by themselves with the help of the bed rail. Once sitting, they can balance and reach across their body to shake your hand without losing balance. They can stretch and point both legs and they can come up to standing, but they are unsteady, even with a walker. What is your patient's mobility level? Hopefully you answered 3P. Remember, a 3N can stand safely without unsteady balance, without swaying, without faltering. So somebody who sways and falters or is unsteady is a 3P. Is it safe for this patient to stand up by themselves while you are not there with them? No, they're unsteady. Is it safe for them to sit up by themselves when you are not there? The answer is yes. They have passed level 2. They've demonstrated safe, independent sitting balance. So as long as they're not confused or unable to follow directions or have high fall risk in sitting, you can let them sit up independently when you are not there. Practice mobility scenario 3. The same patient got up a few times using their walker with an ambulation harness yesterday. They're now steady, standing for 5 seconds, and they can take a couple of steps as long as they have their walker. Now, what is their mobility level? So they've passed 3P, they're able to stand without swaying or faltering. They can take a couple of steps safely with their walker. So they're now a 4A. Is it safe for this patient to stand up by themselves while you're not there with them? According to this screen, the answer would be yes. But remember, you also have to take into account fall risk, ability to follow directions, and consistency. Are they consistently able to stand up by themselves? If this was just one time and the other times they were unsteady, I would not let this patient stand up by themselves if I was not there. So it's still going to require some clinical judgment. With any mobility screen, if in doubt, default to the safer level. Is it safe for them to sit up by themselves when you're not there? The answer is the same as for the last slide. Scenario 4. Your patient rang their bell to help go into the bathroom. Once you raised the bed height, they could stand up without help for 5 seconds without swaying or faltering. They walked to the toilet with their walker and supervision. They then tried to stand up from the toilet by themselves afterwards, and they are unable. So after they've been to the bathroom, they are unable to stand up from the toilet by themselves. What is their mobility level now? They walked to the bathroom, but now they're unable to get up. One of the things that is so important for the mobility screen is it's going to help you detect changes in function with either an environmental change or a physical change within your patient. The bed height was raised to help them stand up the first time, but you don't necessarily have a toilet seat that rises. So from the toilet, this patient is a 3P. From the bed, if they raise the bed, think about this for a moment. You have actually used power to help them stand up. So this in some ways is a trick question, right? Did you use any power to help them stand from the bed? If they couldn't stand from the lower surface of the bed, that would be a 3P. The other thing that this scenario highlights is that sometimes a patient needs help to stand, but then they can walk. Remember the default. If in doubt, use a device to keep them safe. Many times we're guessing the patient's going to be okay to get to the bathroom, and this is where a lot of falls happen. So if in doubt, keep everybody safe and default to the lower level and the more supportive device. Scenario 5, your patient's mobility goal today is walking. They can sit up without help, stretch and point their legs, stand up without assistance, step forward and back without loss of balance. They do not need an assisted device. What's their mobility level? This one's easy. It's independent. Can they get up and go to the bathroom without you there? Yes, as long as they have no fall risk factors, right? So remember, you must know your daily mobility goal. You must know any precautions you need to pay attention to. Perform the mobility screen to see what the patient can do safely by themselves and where they need help. Choose appropriate SPHM equipment to help get them to their mobility goal safely and to their highest level of potential. Let's do a few more scenarios. Let's practice with a few more scenarios. You need to know your mobility goal and precautions, perform your screen, and choose the appropriate equipment. Johnny is 77 years old, weighing 315 pounds. He had a severe CVA 2 days ago and is on the ventilator in the ICU. The medical team agree that Johnny's goal is sitting up until therapy comes in to evaluate him. Johnny's unable to sit up by himself and he cannot roll to either side without a lot of help. The RN has asked you as a unit peer leader to help identify the appropriate SPHM equipment to help Johnny sit up. What's Johnny's mobility level? Level 1 needs help to sit, total assistance. 2, independent sitter. 3P needs help to stand. 3N needs help to walk. 4A, independent. 4, independent. Johnny's level is 1, isn't it? He needs help to sit up. So which solution is the most appropriate to help Johnny sit up today? A, a powered stand aid. B, ambulation harness. C, a bed feature. Or D, a ceiling lift with a seated sling? The answer is that either C or D could help Johnny sit up. So in the bridging document, Johnny's goal was to sit. This highlights the second column. His mobility level down the left-hand side is level 1. So you move across the level 1 row, the level 2, the sitting goal column, and you find the appropriate equipment to help Johnny safely do that. Let's look at another scenario. This is Jenny. She's 75-year-old female weighing 172 pounds. She's on the medical surgical unit with anemia as she's lost a lot of blood related to a GI bleed. The medical team agree that Jenny's goal today is sitting up because of her anemia. She can sit up by herself using the bed rail to help her sit, and she can sit without loss of balance when asked to shake your hand across midline. There's a new CNA on the unit, and she has asked you as unit peer leader to help her decide if she needs any equipment to help Jenny today. What is Jenny's mobility level? A, level 1 needs help to sit. B, level 2 independent sitter. Level 3P needs help to stand. Level 3N needs help to walk. Level 4A, independent. Level 4, independent without a device. This one's another tricky one, isn't it? Because the medical goal is sitting up. The doctors do not want Jenny to stand or walk today. So the mobility level that you're going to screen her to is level 2. She is an independent sitter. Which solution is most appropriate to help Jenny sit up today? A, powered stand aid. B, no equipment needed. C, bed features. Or D, air-assisted devices. The answer is B. Jenny does not need any equipment to help her sit up. Our goal is sitting up, so we're in the second column. Her mobility level was 2, independent sitter. So we go down the left-hand side to find the row, and we go across to the column, and we find that no equipment is needed in bed, but she may need a powered lift to get her up into a chair. Let's meet Jeremy. Jeremy's a 63-year-old veteran who has had a below-knee amputation due to peripheral vascular disease. Jeremy's mobility goal is to stand up on his unaffected limb and transfer onto the commode. So the care team wants him to put weight on his leg and transfer with weight bearing on his unaffected limb. Jeremy can sit up in bed without difficulty. He can balance in sitting, crossing his midline to shake your hand. He can stretch and point his residual limb, but the amputated limb has very little stump below the knee, and he does not have a prosthesis yet. Jeremy is unable to clear his buttocks from the bed to try and stand. What is Jeremy's mobility level? Hopefully you answered level 3P. He needs help to stand or moderate assistance because he was unable to achieve full standing. Which solution is most appropriate to help Jeremy safely stand up today? The answer is A. He needs a powered stand aid. The fact that he failed the test does not mean he cannot or should not stand or walk. His goal is to stand and transfer. You need a powered device to stand him up. Jeremy's equipment, we look first of all at his goal. You go across the top of the document, of the bridging document, to find which column we need to be in according to his mobility goal. And then we go down the left side of the screen to find the row according to his level. Jeremy was a 3P, needing help to stand. And so you'll see any powered device can help him do that. Let's meet Joanna. She's a 75-year-old veteran who's been recovering from COVID-19. Joanna's mobility goal today is standing up and transferring. She's to go for a chest x-ray, and you're about to help her get from her chair to her wheelchair. Joanna can sit forward in the chair without difficulty. She can shake your hand across midline. She can stretch and point both legs. She can clear her bottom. She can stand up without swaying or faltering steadily for 5 seconds. She can march in place and step forward and back without losing her balance. What is Joanna's mobility level? Hopefully you answered level 4. Joanna is an independent ambulator. She did not need an assisted device. Which solution is most appropriate to help Joanna get into her wheelchair today? A, a powered stand aid. B, no equipment. C, a lift. D, a walker. Joanna doesn't need any equipment. She's safe to transfer into the wheelchair by herself. So again, we go across the top of the bridge document and find the goal, standing or walking. We find that she is independent and she can do it without any help. Josie is a 54-year-old female who had a cholecystectomy yesterday for obstructive bowel and has not had a great night. Her mobility goal is walking today. She can sit up, and once she's up, she can balance herself, reach across your body, shake your hand. She can straighten and point both legs. When asked to stand, she can stand, but needs to steady herself with the bed rail. When you give her a walker, she is steady while she stands, but falters and almost stumbles when she attempts to step. She's a little bit dizzy. What is Josie's mobility level? Josie is a 3N. She requires minimal assistance because she cannot walk without stumbling. Which solution is most appropriate to achieve Josie's goal today? The answer is A, some kind of fall arrest device or assisted walking device. She cannot use a walker to walk with without help because she was unsteady and she almost fell with her walker. So you need something more. You need some kind of fall arrest device for her. So Josie's goal was walking. Her mobility level is 3N. And so you go to the column, you go to the row, and then you find the equipment solutions. You walk by a patient room in a CLC, a community living center. You notice the patient's trying to get out of bed. You see level 1 sign outside their door. What is the appropriate action to take? A, keep walking as you're very busy and this is not your patient. B, let the nurse know that their patient's trying to get out of bed. C, go into the patient's room and let them know they should not try to get up on their own and call the nurse while you wait with the patient. Or D, go in and help them get up to the bathroom because they need to go now. The answer is C. Go into their room, let them know they shouldn't try to get up on their own, and call the nurse while you wait with them. Your patient is ready to go home after their clinic appointment. They were able to stand up from their wheelchair and walk to the procedure room chair. You do a quick screen as they're getting up. Watch the video and rate their mobility level. Hey, Jeff, we're going to get you up and get you into the car. Are you ready to go?
I'm ready.
You got your jacket on and everything. You are ready to get out the door. Let's see what you can do. Can you sit forward for me? Take my hand. Good. What about this one? All right. You know the drill. Stretch out. You like to do both legs at the same time. All right. Can you stand for me? Can you stand up? Can you get those feet underneath you? All right. No. Okay. What is this person's mobility level? They are level 3P, moderate assistance. They need help. They need power to stand. Which solution would you use? We're going to use C, a powered stand aid. So let's review. Know if the movement you need to help your patient with is passive or part of their active daily mobility. Secondly, know your patient's mobility goal from your charge nurse or from your medical provider team. Screen the mobility to determine how much of that movement they can do by themselves and how much they need help with. Select the appropriate equipment to safely achieve the mobility goal for both the patient and the caregiver. Always screen your patients before getting them up, even if you know how they moved the last time you helped them. Mobility levels can change throughout the day if the patient is tired or if something has changed medically with them, or if they are getting up from a different surface. Let your nurse know if there's a change in mobility level. Mobility and safety is everybody's responsibility. Sit and shake, stretch and point, stand and walk. These are the 4 basic tenets of your mobility screen. Congratulations, you have successfully completed the module on patient mobility screening and assessment. We hope this has helped you solidify your knowledge and feel confident in screening your patients and appropriately selecting the right equipment to keep you and your patients safe. We know it's been a little repetitive, but that's been by design to try and help you just get practice with the different scenarios, with the levels, and then choosing the mobility solutions based on the goal and the level. Thank you for your service and giving back to those who have served us.